time, we can start the session directly. So the first case is present, an interesting case of cerebral palsy presented by Dr. Kavya, and the moderator is Dr. Gayatri Priyadarshini from SRM Medical College. So over to you, Kavya. Kavya can start presenting.
A kind request to all presenters. We will stick on to 10 minutes of presentation and maybe 5 minutes, 5 to 10 minutes of discussion. So kindly stick on to the time. So we have 4 presentations. Thank you.
Voice
Am I audible, ma'am? Hello.
Yes, audible.
Good afternoon, all. Good afternoon, all. Myself, Dr. Kavya, first year postgraduate resident from SRM Medical College, here to present today's an interesting case of cerebral palsy. Our HOD, Dr. Subhash sir, Dr. Balaji sir, Professor, Department of Pediatrics, and my moderator is Dr. Gayatri ma'am, Assistant Professor, Department of Pediatrics. So, a 3-year-old male child was referred to our department with the following findings. Child was second born to a second degree consanguineous married parents, had delayed attainment of milestones with difficulty in walking, tiptoe walking was present, and a characteristic scissoring gait was present. A diagnosis of cerebral palsy with spastic diplegia was made, and child was on physiotherapy and occupational therapy for the past 1.5 years and had no significant improvement and was then finally referred here. So after taking a complete history taking and examination, the following evaluation was done. A 3-year-old male child brought with history of late walking and frequent falls with gradual progression of stiffness of lower limb with difficulty in walking unassisted. History of difficulty in holding on slippers. History of difficulty in changing diapers with history of urinary urgency and tiptoe walking was present, but child was able to button the shirts, scribble. There was no difficulty in raising from lying posture or difficulty in lifting arm above head. Child was able to recognize his mother, and child was interested in surroundings. No difficulty in chewing or deviation of angle of mouth. Child was able to appreciate touch, appreciate cold and pain. No history of any seizures, headache, vomiting, and no regression of attainment of previously attained milestones was present. So predominantly there was involvement of lower limb compared to the upper limb, and there was no history suggestive of cranial nerve involvement or sensory involvement. Moving on to developmental history, child had the delayed gross motor development with a DQ of around 33%, which was predominantly for lower limb. As for upper limb, child was able to throw ball above his head. And child had age-appropriate developed social and speech milestones. So this shows there is a developmental delay with dissociation of motor domain, especially over lower limb. Antenatal history, child was a second born of second degree consanguineous parents. Mother age at the time of conception was 32 and father at the time of conception was 42. First trimester, second trimester and third trimester history was uneventful. Natal history, child was delivered by LSCS, which was vertex presentation, term delivery and birth weight was around 3.5 kg, appropriate for gestational age. Baby cried immediately and at birth and had normal transition. No history of NICU stay or NNH. This shows there is no significant perinatal history or no signs of birth asphyxia. Moving on to immunization history, child is immunized till date as per NIS. Socioeconomic history, child belongs to lower middle class according to modified Kupaswamy scale. And diet history, child has a calorie deficit of around 300 kilocalories per day and protein of around 4 gram per day. Coming to the family history, history of similar complaints is present both in mother and also elder siblings, and no evaluation was done. So elder sibling also had similar complaints with delayed milestones, not able to walk unassisted, but goes to school and has good scholastic performance. So to summarize, this 3-year-old male child, who is a second born of second degree consanguineous married parents, immunized till date, belonging to lower middle class socio-economic background, with a calorie deficit of approximately 300 kilocalorie per day and protein of 4 gram per day, presented with complaints of progressive weakness involving lower limb with urinary incontinence, with no significant perinatal history suggestive of birth asphyxia, with a positive family history of similar illness noted in both mother and elder sibling, and had developed delayed motor milestones with age appropriate social and language milestones. So, we thought it is suggestive of hereditary causes more than that of cerebral palsy, as there was no significant perinatal history suggestive of birth asphyxia, and there was a positive family history with similar illnesses noted in both mother and elder sibling was present. So moving on to general examination, there was no pallor, icterus, cyanosis, clubbing or lymphadenopathy. Anthropometry was within centiles and vitals were stable. Head to toe examination, child had no microcephaly, no hyperpigmentation or no dysmorphic facies, and child had Caesarean gait. Systemic examination, cranial nerve examination was normal. Higher mental functions were normal. Child was conscious, alert, and behavior, child was maintaining eye contact. Coming to motor examination, child had mildly reduced bulk over bilateral lower limbs. Tone, right and left, upper limb was normal. Lower limb, there was increased tone, hypertonia with bilateral spasticity. Power, right and left, upper limb power was 5 by 5 and 5 by 5. Lower limb power was 3 by 5 on both right and left. Reflexes, there was exaggerated deep tendon reflexes with plantar showing bilateral extensor with a positive Babinski sign. Sensory system, child was able to perceive pain, cerebellar functions were normal, and other system functions were normal. So to summarize after examination, this 3-year-old male child, who's a second born of second degree consanguineous married parents, showed motor deficit with progressive stiffening of lower limbs, with sparing of upper limb, with no significant perinatal events, with positive family history, with age appropriate language and social milestones. On examination, child had no dysmorphic facies, no microcephaly, presented with tip-toe gait, with intact higher mental functions, normal cranial nerve functions, with spasticity of lower limb, and reduced power in lower limb with positive Babinski sign with no regression of previously attained milestones. So with this progressive history of bilateral lower limb spasticity, having positive family history and no significant perinatal history, uh, neurodegenerative disorders of inherited disorders was kept in mind, and all routine investigations and MRI brain with MRI whole spining was also normal. So, as this child, which was previously diagnosed to be a case of cerebral palsy, points favoring towards cerebral palsy were delayed motor milestones, spasticity, and Caesarean gait. But points which were not favoring for cerebral palsy were progressive course of the disease, no signs of birth asphyxia or significant perinatal history, no microcephaly, there was normal cognition, no speech, vision, or hearing impairment, no involuntary movement, an MRI brain was normal, and a significant positive family history was present. So our differential diagnosis were first hereditary spastic paraplegia, as most of the findings were present in our child with lower limb spasticity, tiptoe walking, brisk deep tendon reflexes, preserved cognition, positive family history, and impaired bladder control. MRI brain usually shows thin corpus callosum, but which is not diagnostic. Second differential was adrenoleukodystrophy. It also presents with progressive spastic paraparesis, which is seen in our case, but the usual age of presentation is more than 4 years of age, and child will have cognitive decline with signs of adrenal deficiency like hyperpigmentation, and MRI brain usually shows white matter changes, which is not seen in this case. Next is DOPA responsive dystonia. It also has normal cognition. Tiptoe walking will be present and MRI brain will be normal. But usually there will be progressive dystonia and it responds well with levodopa, and there will be diurnal variation. That is there will be progression and worsening of weakness as the day progresses, which is not seen in our case. Next is glutaric aciduria type 1. Child will have macrocephaly and involuntary movements like dystonia or chorioathetosis, which is not seen in this case, and MRI brain will show widened sylvian fissures. So we thought, diagnosis of a hereditary spastic paraplegia is likely to be made, and then genetic testing was done, and the whole exome sequencing done, which showed homozygous autosomal recessive likely pathogenic variant involving ALS2 gene mutation. So ALS2 gene mutation, it results in 3 rare early onset motor neuron diseases, which is infantile onset ascending hereditary spastic paralysis, juvenile primary lateral sclerosis, and juvenile amyotrophic lateral sclerosis. So the history with our case, it is likely to be infantile onset hereditary spastic paralysis, as the mode of inheritance is autosomal recessive, and age of onset is 1 to 3 years of age, and the symptoms is usually spastic paraparesis, which is seen in our child, and due to progressive weakness, the child will be in wheelchair at around 10 years of age. Coming to juvenile amyotrophic lateral sclerosis, the inheritance is usually autosomal recessive or autosomal dominant, and the age of onset is usually 4 to 8 years of age, and there will be spasticity, cognitive impairment with dysarthria, and due to rapid progression of disease, their death might occur within 17 years of age due to respiratory failure. So with progressive course of bilateral lower limb spasticity, a positive family history, no significant perinatal history, and whole exome sequencing showing ALS2 gene mutation, a diagnosis of hereditary spastic paraparesis was made. So coming to hereditary spastic paraplegia, it is an inherited neurodegenerative disorder with progressive degeneration of corticospinal tract, presenting with lower limb spasticity and weakness. It is of two types, pure HSP, which is uncomplicated type, and complicated HSP. So pure HSP, there will be spastic paraplegia with bladder involvement, and in case of complicated HSP, there will be pure HSP with neurological or systemic abnormalities, that is cognitive or visual loss can be seen. So the most important early or presenting sign is bladder dysfunction, that is urinary urgency. In case of pure form of HSP, there will be no speech or upper limb involvement, and pes cavus and hammer toes can be seen. Coming to the inheritance pattern, it can be autosomal dominant, recessive, or X-linked recessive. Autosomal dominant is usually pure form, which is related with SPG4 and SPG3A gene, and autosomal recessive is either pure or complicated form, and SPG 5, 24, 28, and 30 is pure form, and SPG 7, 11, 15, 20, 21, and 44 is complicated form. As our whole exome sequencing shows ALS2 gene mutation, it is associated with SPG 30, which is a pure form of HSP. So the diagnosis is usually made with bilateral lower limb weakness and lower limb spasticity with a positive family history and urinary involvement. So the management, there is no curative therapy. Symptomatic treatment can be given. So for spasticity, baclofen can be given, and tizanidine or botulinum injections can be given. For bladder dysfunction, anticholinergics, oxybutynin can be given. Coming to physical therapy and rehabilitation, physiotherapy and occupational therapy, gait training, and orthostatic devices can be used. Genetic counseling for future pregnancies has to be done. So take home points, not all spastic diplegia is cerebral palsy. If there is no perinatal insult and with progression of symptoms or positive family history, diagnosis of cerebral palsy has to be reconsidered. HSP is a close mimicker of spastic diplegia, and it will have a positive family history with history of urinary involvement, lower limb spasticity with normal cognition and normal MRI bin. So management, HSP rehabilitation emphasizes more on the preservation and adaptation of progressive course of the disease, while CP rehabilitation focuses on the developmental goals. References. Thank you.
Thank you, Dr. Kavya. Just to stop the. Okay. Thank you, Dr. Kavya, for your excellent presentation.
Thank you. Thank you.
Good afternoon, ma'am.
Thank you, Dr. Kavya. Your excellent presentation. Right from the history, we can straight away rule out cerebral palsy because you said it is progressive in nature and a strong family history. Plus, I think involvement of lower limbs, which is only paraplegia, is not common in cerebral palsy. If it is only diplegia that is common, and upper limbs should have minimal involvement. So right from the beginning, your history points out to us some neurodegenerative disorder and not a CP. And you said no history of birth asphyxia, so you rule out CP. Do all cases of CP give a history of birth asphyxia? Hello? Do all cases of CP? I'll come there. Do all cases of CP give history of CP, birth asphyxia?
Not all cases, ma'am.
I think I'll come there and wait. Put that volume. I think, but let the moderator give his comments.
Good morning, madam. Good morning, madam. I am Dr. Robert, neurologist in SRM Medical College, madam.
Okay. Good morning, doctor.
Madam, I congratulate Kavya for the excellent presentation, madam. She has covered everything. I will add a few more points, madam. This child, it is relatively very early onset, madam. But in late onset cases, we have to think of other acquired diseases also, like other spinal cord disorders like demyelination, viral infections and all, madam. But this case, as it is very early onset, this is straightforward case, madam. The other thing will be the treatment aspect in severe cases with very much gait abnormalities. Then we can try baclofen intrathecal pump also, madam. That the efficacy is very much more than the oral baclofen therapy. So we can try that in some centers they are doing, madam, intrathecal continuous baclofen infusion. The one more point will be in this ALS2 mutation. There are other two diseases phenotypes is also there. Familial ALS and PLS. There is one way of differentiating ruling out those disorders, madam. We have to look for posterior column signs in the legs. So loss of vibration in the ankle or great toe, if we detect that we can eliminate ALS group of disorders, madam. In ALS group of disorders, the involvement will be pure motor neurons. The posterior columns will not be affected. In older patients, we do sensory potentials like electrophysiological tests like somatosensory evoked potential. These tests will help to eliminate the other two motor neuron disorders, madam, ALS and PLS, familial. And the program, is the mother still walking? I would like to ask this to Kavya.
Sir, actually the mother
Is
is
she
not.
ambulant?
Sir, Dr. Gayatri here, sir.
Tell me,
Sir,
madam.
mother is not able to walk, sir. Mostly accompanied by grandparents or the father, actually. We
Okay,
haven't
okay.
seen the mother per se.
Okay. How old is she, madam? Age?
She is like 35, sir.
Okay.
Mother is
So
35.
the age also excludes ALS, madam. Most of ALS patients will die early, madam, within 1 or 2 decades. That's all from my side, madam. Okay.
Actually, if there is I mean, if you suspect CP and then if there is no history of asphyxia, you must always think of neuronal migration disorders and also certain inborn errors of metabolism like arginase deficiency and PKU also can present as a case of cerebral palsy. This is a straightforward case where you have done, there is a progressive weakening and also stiffening with you have done also whole exome sequencing. But history wise, whenever there is no history of birth asphyxia, we have to think of neuronal migration disorders and inborn errors of metabolism like arginase deficiency and CKU. Thank you. Is there any genetic gene therapy or anything for this disorder, sir?
No, madam, not yet, madam. Not yet found, madam. For other some genetic disorder, there are therapies like muscular dystrophies, SMA and all. We have genetic therapies, madam. For HSP, there is no disease modifying therapy yet, madam.
Thank you, sir.
Okay.
We go on to the next case. Presented by Dr. Suhani Ghosh, a story of a floppy infant from genetics to reality. The moderator is Dr. Revati from Chettinad Hospital and Research Institute. Over to Dr. Suhani.
Good afternoon, ma'am. Is my screen visible, ma'am?
Dr. Sohani, you're audible.
Yes, ma'am. I'll start. Good afternoon, everyone. I'm Dr. Suhani, a second year postgraduate from Chettinad Medical College. My moderator is Dr. Revati ma'am. So I'm going to talk about a case of a story of a floppy infant from genetics to reality. So I'll start with the case discussion. A 4-month-old male child brought by the parents with complaints of decreased movements in the bilateral lower limbs for the past 1.5 months and complaints of generalized floppiness for the past 1.5 months. So there's no history of fever, no history of vomiting, loose stools, or lethargy. There's no history of difficulty in changing diapers. There's no history of feeding difficulty. No history of involuntary movements, no history of abnormal eye movements, and no history of trauma. And it was a spontaneous conception. All antenatal scans done were normal. Iron and folic acid was taken. 2 doses of injection TT was given. The mother is a known case of hypothyroidism on tablet Tylenol for the past 2 years. There's no history of GDM, PIH, fever with rash or anemia. Birth history, it was a term 37 weeks plus 3 days, boy baby. Birth weight of 2.45 kg and LSCS in view of previous LSCS in labor. There was no history of NICU admission and TFT done at 48 hours of life was normal. Past history, the child had previous hospitalization at 1 month of age at CHRA in view of bronchiolitis, and USG cranium was done at Chettinad Hospital was found to be normal. So family history, it was a third born child born out of non-consanguineous marriage. Mother is a known case of hypothyroidism on tab thyronorm. Development history, so gross motor, neck folding was not present. Social smile was present and language cooing was present. Child is immunized up to 3.5 months of age according to national immunization schedule. On examination, on admission, child was active, alert, and afebrile. There was no pallor, icterus, or cyanosis. Vitals, heart rate was 119 per minute, respiratory rate was 30 per minute, saturation was 98% under room air, CRT was less than 3 seconds, peripheral pulses were well felt, and CPG was 95. On head-to-toe examination, skin BCG scar was present, head was normal in size and shape, ears, eyes, and nose were normal, genitalia was normal, bilateral testis descended, and spine was normal. Anthropometry-wise, the weight was 5.7 kg, which falls under -2 to -3 and showed underweight. Other parameters were normal. On systemic examination, CNS examination done showed tone was decreased in all 4 limbs. Power was 3/5 in upper limbs and 2/5 in lower limbs. Reflexes, superficial reflexes were present. Plantar reflex showed a flexor response. Deep tendon reflexes were absent. Cranial nerve examination was normal. Cerebellum, there was no nystagmus present. Other systemic examination was found to be normal. 180-degree flip test was done, which on pull to sit, we can see that the child has complete head lag. On held sitting, there was the back was rounded, head sagged forward completely. Held standing, there was no weight bearing present. Vertical suspension showed slips through the hands, and ventral suspension, the head hangs down completely. And on prone position, the child lies flat with no lifting of the head. So course in the hospital, radiological investigations were done. MRI brain along with MRA, MRB and MRS was done, which was found to be normal. MRI spine was normal. Echo done was normal. Blood investigation, CBC done showed anemia with HB of 10.4. Peripheral smear showed normocytic normochromic anemia with 4 microcytic hypochromic cells. LFT, RFT, serum electrolytes, calcium and magnesium levels were done, which was found to be normal. Creatine kinase levels were mildly elevated, 265. Serum ammonia and lactate levels were done, which was also found to be normal. Ophthalmology opinion was obtained for fundus examination. It was found to be normal. Neurology opinion was obtained and orders were followed. So genetic screening for whole exome sequencing plus SMA mutation analysis. MLPA sample was sent and child was hemodynamically stable and discharged. Following which we received the report of the genetic study and found that on SMA mutation analysis in MLPA, SMN1 and SMN1 gene On exons 7 and 8, there was homozygous deletion, which is pathognomic of spinal muscular atrophy. SMN2 gene was present. So the approach to a floppy infant, the word floppy can mean decreased muscle tone, which is hypotonia, decrease in muscle power, which is weakness, and ligamentous laxity and increased joint mobility, which is joint laxity. The term floppy infant means impairment of the ability to sustain postural control and movement against gravity, exhibit poor control of movement, delayed motor skills, and hypotonic motor movement patterns are present. So based on the approach to site of the lesion, there are various causes for a floppy infant. So when we suspect a disorder in the cerebral cortex, it can be due to hypotonic CP, it can be because of CNS structural disorders due to trauma, cerebral malformations, or birth asphyxia. It can also be due to metabolic problems. Then in case of anterior horn cell, hereditary causes SMA and acquired causes poliomyelitis. There can be demyelinating or axonal neuropathies in case of nerve fiber involvement. At the level of NMJ, myasthenia, botulism has to be considered. In case of tendon and supportive tissue level, we have to consider connective tissue disorders and mucopolysaccharidosis. In case of the level of muscular dystrophies, congenital myopathies, and metabolic myopathies have to be considered. Other acquired causes like dermatomyositis, polymyositis, endocrine myopathies, and steroid myopathy also has to be considered. So based upon the level of the lesion, the clinical presentation varies. So usually in central injury cases, the strength is normal or increased, and below the level of anterior horn cell, peripheral nerve, NMJ, and muscle, strength will be decreased. Deep tendon reflexes will be normal or increased in case of central causes. Anterior horn cell, it is absent. Peripheral nerve also, it is absent or decreased. NMJ, it can be normal or decreased. In muscle, it will be decreased or absent. Babinski reflex is usually absent in other cases. Only in central case, usually it can be positive. Infantile reflexes are persistent in case of central causes. Muscle fasciculations are mainly prominent in case of anterior horn cell disease. Sensation can be increased or decreased in case of peripheral nerve involvement. Facial weakness is usually present in case of NMJ lesions. So we have usually when we have case of floppy infant, we'll divide it into floppy strong or floppy weak. So floppy strong infants, usually they have increased tendon reflexes, extensive plantar response, global developmental delay, microcephaly, and axial weakness. So in these cases, usually suspect upper motor neuron lesion, and we can do CT MRI and find HIE changes, cerebral malformations, or we can do genetic studies and karyotyping, fish studies, and rule out trisomy 21, Prader-Willi syndrome, and Zellweger syndrome. In case of floppy weak infant, they usually are hypo to A reflex is present, selective motor delay is present, normal head circumference and growth, there's preserved social interaction, there's weakness of anti-gravitational limb muscles, tongue fasciculations are prominent. So in all these cases, we suspect a LMN lesion type of lesion. We can further evaluate the child with creatine kinase assay, EMG, and nerve conduction studies. Further, for ruling out spinal muscular dystrophy, congenital myotonic dystrophy, and congenital muscular dystrophies, we can do genetic testing, and muscle or nerve biopsy can also be done. So the most common causes of floppy infant are Down syndrome, hypothyroidism, SMA type 1, 2, and 3, and congenital muscular dystrophy and congenital myopathy. So SMA is an autosomal recessive neurodegenerative disorder, which is characterized by progressive symmetrical proximal muscle atrophy and weakness. It is one of the most common genetic neuromuscular disorders with incidence ranging from 1 in 6,000 to 10,000 live births. The onset of manifestations can vary from prenatal to adulthood depending on the type of SMA. So phenotype is caused by biallelic loss of function variants of SMN1 gene, which is survival of motor neuron 1 gene, which leads to irreversible atrophy and degeneration of the anterior horn cells in the spinal cord and brainstem. So the SMN1 gene is found on chromosome 5q13 locus and has 9 exons and codes for the SMN protein. So the SMN protein has an important role in the assembly of small nuclear protein complexes and in messenger RNA splicing. So because of the absence or reduction of this SMN protein, there's disruption in the formation of the SNRMPs and affects the genes involved in motor neuron circuits. So SMN protein is ubiquitously present in all cells, including neurons. It is hypothesized that the function of SMN protein is either specific to lower motor neurons or lower motor neurons are more sensitive to reduced levels of SMN protein, which results in the degeneration of these neurons. So there's another gene called chromosome called SMN2, which is present on 5q13 locus chromosome. So when the amount of SMN2 gene, the number of copies is increased, the amount of functional protein generated by SMN2 will partially compensate for the lack of SMN1, which leads to the milder phenotype, that is SMA type 2, 3, and 4. So number of copies of SMN2 will act as a modifier of severity of the disease phenotype. So more the number of copies of SMN2, the milder will be the phenotype. So we have various types of SMA, which SMA type 1, type 0 is age of onset is prenatal, and the survival is usually less than 6 months. SMA type 1 usually presents at less than 6 months, and survival is up 8 to 18 months. And the other types of 2, 3, and 4, usually 4 is present, age of onset is adulthood, and they have a normal lifespan. Laboratory diagnosis, CPK levels can be normal or mildly elevated in case of SMA. EMG, although it is difficult to perform in a young infant, but in older child or adult, features suggestive of motor neuron or motor axonal involvement is present. Abnormal spontaneous activity in the form of fibrillation potentials is also seen. So confirmation of the diagnosis is usually by molecular genetic testing of the SMN1 gene. So management, until recently, only supportive and symptomatic management was possible for SMA in the form of regular physiotherapy and multidisciplinary care for respiratory failure, nutritional compromise, scoliosis, and joint contractures. But recently, there are approved therapies and ongoing clinical trials for SMA based on SMN2 dependent and SMN2 targeted approaches. So first is nusinersen, which is marketed as Spyrenza, which is used for treatment of all types of SMA. It is administered intrathecally with the dose being 12 mg per administration, or a total of 4 loading doses are administered with first 3 loading doses at 14 days interval and the 4th loading dose 1 month after the 3rd dose. Maintenance dose is administered once every 4 months. Next is the onesmoga gene, which is marketed as Zolgensma. So it is given as a one-time slow IV infusion. It is reported to result in significant improvement in motor milestone and prolongs the survival of SMA child without ventilator dependence. However, it is very expensive at present. Next is Risdiplam and Branapam, which are experimental drugs. Risdiplam is approved by US FDA in 2020 for the use in patients of age more than 2 months. The dose being 0.2 mg per kg per day for patients aged 2 months to 2 years, 0.25 mg per kg per day for more than 2 years but less than 20 kg, and 5 mg per day for more than 20 kg child. So from 2018, newborn screening for SMA has been added to recommended uniform screening panel in the US and is currently available in the few US states at present in an effort to initiate treatment as early as possible. So genetic counseling and prenatal genetic testing is very important in case of an SMA child. So is usually inherited in an autosomal recessive manner. In almost 98% of the couples with an affected child, both partners are heterozygous carriers for one one gene mutation each. Only in around 2% of the cases, only one partner may be a carrier and the other mutation may have arisen de novo. When both partners are carriers, there is 25% risk of recurrence of disorder in each offspring. So prenatal sampling can be done through chorionic villus sampling at 11 to 13 weeks or through amniocentesis at 16 to 18 weeks, and targeted mutation analysis can be done to find out whether the gene responsible is present or not. Carrier screening of extended family members is also suggested when an individual is diagnosed to have SMA in the family. Thank you.
I call upon the moderator to give their comments.
Good afternoon, ma'am. Yes, ma'am. Yes, ma'am. This case presented with a floppy infant, 4 months old, with hypotonia, and on examination, the reflexes were absent, and we suspected we sent for genetic analysis, and they found to be diagnosed with SMN type 1. And further, for treatment and follow-up, we have referred the child for further medical management, ma'am.
Did the mother complain of any decreased fetal movements?
No, ma'am. No, ma'am. Antenatally, history was collected, but mother didn't notice, mother didn't give such history, ma'am.
There are two possibilities. No, she herself is hypothyroid. So, the child can be hypothyroid also. So there also there will be decreased fetal movements, and here in spinomuscular atrophy also the antenatal period there can be decreased fetal movements.
Yes, ma'am. But TFT was normal, ma'am. Thyroid function test was normal, ma'am.
Okay.
Yes, ma'am.
Thank you. Excellent presentation. If there are no other, it is open to the audience for any questions. The neurologist,
It was good.
Dr. Robert, please comments.
Madam, this must be type 2, type 2, madam.
Okay.
2, because the copy number is 2. They have said it is copy number 2. So
Okay.
this child can attain some sitting and all, madam. We have to see. And recently they have cut down the cost of this risk dip plan. Our government has released the thing to manufacture in India itself, and the cost has come down on cost of risk dip plan. So we can try for this child, ma'am.
Actually, it increases the SMN protein. That's the mechanism, isn't it?
Yes, madam. Yes, madam. SMN protein. The severity depends upon the presence of SMN 2 copy numbers, madam. If copy numbers is 4 and above, the severity will be less, madam.
Sir, Dr. Robert sir, only
Yes,
one
sir.
doubt. So
Yes,
they
yes,
are
sir.
doing this crowdfunding for costly drug. So how is the prognosis after the treatment? So they recover, how much they recover, sir?
They achieve some milestones, Balaji. They will not become normal. If the child is very young, it can achieve head control, sitting without support, or some children will attain standing alone, Balaji. Not they will not become ambulant anyway, Balaji. They will attain some amount. They need lifelong other rehabs and supportive care.
Okay, sir. I think that everyone should know. They project as
Big,
though it is a miracle drug curing.
no, Balaji, no, Balaji. They care. The independent ambulances itself is very rare, even with these therapies.
And regarding the presenter, I just
No,
didn't mention about the fasciculation. I was just looking for it.
fibrillation.
Dr. Suhani, did you look?
The fasciculations, fibrillations in the tongue, was it present? That's what Dr.
No, ma'am, there was no tongue fasciculations present.
So the other means, you mean this is that Wernicke-Hoffman, you want to fit it into that infantile form, Wernicke-Hoffman? And the Wernicke-Hoffman. It's early infantile is. We go on to the next topic. Dr. Priyanka, genetic counseling in Down syndrome. The moderator is Dr. Pragada, Dr. Kamakshi from Dr. Kamakshi Memorial Hospital.
Ma'am,
Over to you, Dr.
ma'am, Sundari ma'am.
Yes,
Ma'am, you're not audible, ma'am.
I'm not audible.
Yes, ma'am.
இங்க பாரு. இங்க பாரு.
Yes, ma'am. Yeah, it's fine, ma'am. It's fine now.
Okay.
Yeah. If there's no further question, can we move on to the next presentation, ma'am?
We go on to a case of genetic counseling in Down syndrome by Dr. Priyanka. The moderator is Dr. Prahada from Dr. Kamakshi Memorial Hospital. Over to you, Dr. Priyanka.
Yes, ma'am. Ma'am, am I audible, ma'am?
Yes, pa. Yes, start presenting.
Good afternoon, everyone. I'm Dr. Priyanka, DNB Pediatric resident. My topic today is about genetic counseling in Down syndrome. My moderator, Dr. Brahada, ma'am, Senior Consultant Pediatrician from Kamakshi Memorial Hospital. Thanks to our clinical lead, Dr. Aishwari, ma'am, for giving me the opportunity to present this case. So, background history: a 38 days old girl baby was diagnosed as Down syndrome, referred to our genetic OPD for further evaluation, follow-up, and management. Antenatal history: it is a third degree consanguineous marriage, spontaneous conception, history of hypothyroidism in mother, on tablet thyroxine 12.5 microgram. The first trimester ultrasound showed a single live intrauterine gestation, 13 weeks. NT was 0.9 millimeter, nasal bone seen, ductus venosus flow was normal, and there was no tricuspid regurgitation. First trimester screening, trisomy 13, 18, and 21 was low risk. And second trimester, the quickening was felt at 20 weeks of gestations. An anomaly scan done at 21 weeks, there was no congenital anomaly and no soft markers was present. And third trimester done at 37 weeks of gestations, AFI was 8.5 centimeter. Fetus was in breech presentation. The fetal weight was 3,248 grams. Birth history: the child is born in Thoothukudi. Term: birth weight of 2.65 kg. Elective LSCS in view of breech presentation and cried immediately after birth. Postnatal history: the baby was breastfed on day 2 of life, passed urine and meconium within 24 hours of life, and history of NNH treated with phototherapy. There was no history of NICU admission. In view of poor sucking, the baby was initiated on express breast milk. This was a family pedigree. It is a third degree consanguineous marriage, and no other significant family history was present. In view of facial dysmorphism, child was evaluated with metabolic and genetic workup and referred here for further management with the karyotyping report. On examining the child had a flat facial profile, mild upslanting palpebral fissure, a broad forehead, broad nasal bridge, bulbous tip of nose, short columella, simian crease in right hand, anterior fontanelle 4.5 cross 4 centimeter. Anthropometry was within normal limits. Systemic examination showed CVS S1 S2 hurt, pansystolic murmur was present, RS bilateral artery was present, per abdomen soft, and there was no organomegaly. CNS hypotonia was present, spine normal. So, clinical diagnosis of Down syndrome was arrived, and investigations done showed a total count of 7,000 with lymphocyte predominant of 53.8%. ANC and ALC was within normal limits. Hemoglobin was 16.5, platelet 1.4 lakhs, and calcium was normal. The newborn screening done was negative. Ultrasound abdomen was normal. Echo done showed a large perimembranous VSD 6.2 cross 5.9 millimeter. ASD was there. PFO of 3.3 millimeter left to right shunt, and severe pulmonary artery hypertension was present. Hussein carnitine profile was normal. Blood TMS initially showed a raised glycine level, and the repeat glycine level was within normal limits. So karyotyping done showed a female karyotype, and you can see a translocation was happened from 14:21. Inference is the abnormal female karyotype pattern with a derivative chromosome having Robertsonian translocation between 14 and 21, breakpoints being Q10 and Q10 respectively, along with extra copy of chromosome 21 was present. So the final diagnosis of Down syndrome with the translocation type was arrived. So the child was planned for hearing evaluation with OAE, BERA with behavior response audiometry, and ophthalmology evaluation. Pediatric cardiologist opinion was obtained. The child was initiated on furosemide and digoxin. Couple karyotyping for the parents was advised. And child was advised, follow-up advice was given to the parents, where advised annual hearing and ophthalmological evaluation, CBC and peripheral smear at birth followed by annually, thyroid profile, follow-up in the child development center, and pediatric cardiologist follow-up should be there. Coming to the discussion, genetic counseling in Down syndrome includes the objectives are natural history, clinical features, comorbidities, rehabilitation, follow-up, cytogenetics, recurrence risk, and prevention. Down syndrome is a genetic disorder caused by the presence of all or part of a third copy of chromosome 21. One child in 850 live births is born with the Down syndrome, which affects 23,000 to 29,000 children born in India every year. Why to know about Down syndrome? Because it is the most common intellectual disability. It is most commonest cause of intellectual disability, and it is the only autosomal aneuploidy with the longest survival. Children and adults with Down syndrome have a lot of comorbidities, and it's imperative for every pediatrician or adult physician to know about the natural history, follow-up management of children and adults living with Down syndrome. So clinical features, the phenotypic features of Down syndrome is due to the extra copy of chromosome 21 leading to gene dosage imbalance. Hall's criteria includes flat face, eye upslanted palpebral fissure, ear is small and dysplastic, neck short with reddened skin, hypotonia, poor motor reflex, hyperflexible joints, simian crease, short fifth finger with clinodactyly, and pelvic dysplasia. Phenotypic features in face includes a flat facial profile, flat nasal bridge, epicanthal fold, upstanding palpebral fissures, and protruded trunk. And in hand, you can see simian crease, saddle gap, and short fingers and toes, which indicate of brachydactyly. Seborrheic dermatitis is one of a common finding in child with Down syndrome, and they may also present with duodenal atresia, as you can see in double bubble sign in X-rays, and absent epiphysis will be there. So comorbidities in Down syndrome includes cardiac, which the most common complication is atrioventricular septal defect. Other complications includes BSD, ASD, PDA, and TOF. Thyroid, hypothyroidism is the most commonest, which could be subclinical, congenital, or autoimmune. And other complication includes Graves' disease. And in ENT, hearing loss will occur in 75% of the cases, followed by recurrent otitis media, and obstructive sleep apnea can also occur. And eye refractive error is the commonest complication the child will have, followed by strabismus, cataract, nystagmus, and nasolacrimal duct. And in hematology, transient myeloid dysplasia can occur. Polycythemia, thrombocytopenia, AML, and ALL could also occur. GIT, congenital GI defects like duodenal atresia and pyloric stenosis are more common in Down's children, and they may also present with constipation, celiac disease, and GERD. Musculoskeletal includes atlantoaxial instability, hypotonia, pes planus, and in CNS, intellectual disabilities, ASD and ADHD could occur. Seizures can occur, and early onset of Alzheimer's disease is one of the important comorbidities in Down syndrome. And development delay could be in language, communication, and social. And in endocrine, Down's child generally will have a short stature and hypogonadism could be there. And dermatology, seborrheic dermatitis, cirrhosis, and palmoplantar keratoderma can also occur in Down's child. So rehabilitation, physiotherapy with speech stimulation should be initiated as early as possible, at least by 3 months of age. Occupational therapy, cognitive and behavioral therapy should be initiated at an appropriate time. Psychiatric support, especially during the adolescent stage, should be given, and inclusive education is recommended for those children. Follow-up of the child, echocardiography should be done at birth, at least by 6 weeks of age. Thyroid profile can be done as a newborn screening or as TSH at birth, and follow-up should be done at 6 months, followed by 1 year, and then annually. CBC and peripheral smear should be done at birth, followed by 1 year and annually. Audiological evaluation at birth, followed by 6 months, at 2 years, and then annually. Ophthalmology evaluation should be done at birth and at 2 years, and every 2 years, followed by every 2 years. And for GA, history of delayed passage of meconium should be noted, since a child will have more prone for Hirschsprung disease. And at follow-up, screening for celiac disease with IG and tissue transglutaminase antibodies can be done. And dental, the examination should be done at 1 year, followed by annual examination should be done. So coming to the cytogenetics of Down syndrome, it includes 3 variants. One is meiotic non-destruction, which is the cause for 95% of Down syndrome, followed by translocation, which is 4%, and mosaicism, which is 1%. The meiotic non-disjunction is an error in the meiotic phase of the cell division. 90% is of maternal origin, the remaining is because of the paternal origin. And in Robertsonian translocation, it's due to the long arm of the chromosome 21 is attached to another chromosome, mostly an acrosome, which includes 14, 15, 21, and 22. It is of two types, which could be familial, 25% of the cases, or it could be a de novo, which occurs in 75% of the case of Down syndrome. And mosaicism occurs post-zygotically cell division error, and it will lead to two cell lineage, one with a normal number of chromosome and another with an extra number of chromosome, which is the 47 chromosome could be present. And these cytogenetics, while we are seeing in the karyotyping, in trisomy 21, 3 copies of chromosome 21 will be seen. In mosaicism, both 2 copies of chromosome 21 and also 3 copies of chromosome 21 will be seen. In translocation, first image is showing a 14 is to 21 translocation, and second image is showing 21 is to 21 translocation. So, what is a recurrence risk? Whenever you are diagnosed a case of Down syndrome, the child should undergo karyotyping. If it is trisomy 21 or mosaicism, the chance of recurrence in the next pregnancy is 1%. If the child has Robertsonian translocation, its recurrence risk depends on the chromosome involved and also the sex of the carrier. The karyotyping analysis for both the parents should be advised. And if it is a 21 is to 21 translocation, it could be either in father or mother, it is 100% recurrence risk in next pregnancy. Or if the translocation involves other than 21, and if it's the father is a carrier, it has less than 1% of recurrence. And if mother is a carrier, there is 50% chance of recurrence in next pregnancy. And if both the parents is not the carrier and the child had a Robertsonian translocation and it's a de novo, the next pregnancy, the chance is only 1% each. And if children born to a Down syndrome mother has 50% chance of having Down syndrome, and male with Down syndrome are mostly infertile. So how do you going to prevent Down syndrome? Prenatal screening of Down syndrome should be done for all antenatal mother irrespective of the age. Couple karyotyping should be done in case of translocation type. And if the first child is affected with Down syndrome, invasive diagnostic testing can be offered in the second pregnancy. Thank you.
Dr. Priyanka. Now,
Yes,
I request the chairperson, Dr. Pragada, to give her comments.
Good afternoon, ma'am. This is Dr. Prada, Senior Consultant Pediatrician. This child was referred to us with the karyotype. The child had a translocation 14 to 21 and is in follow-up in our OPD. We wanted to present this case for the just to touch upon the natural history, the clinical features, and the follow-up and the management of the child, ma'am. And to know, I mean, how about counseling when it comes to genetic counseling, that we have to start with the natural history of the disease, tell them the present clinical features, how to rehabilitate the present child, and also talk about the prenatal screening for the second child.
The case was an excellent presentation, but we would have benefited if we have gone along the steps for genetic counseling, which most of us are lacking. So that could have helped us much more. What are the points to address in a step in a genetic counseling? Thank you.
Thank you so much.
Next, we'll go on to the next case, the expanding head and the collapsing neurons by Dr. Vaibhav Ramesh Jamdari. The moderator is Dr. Shanti Ramesh from Sri Balaji Medical College and Hospital. Over to you, Vaibhav.
Dr. Priyanka, can you please stop sharing? Ma'am, I would like to add this point. There is something called as non-invasive testing for the Downs, which is cell-free DNA testing, which can be done from the maternal mother itself. It has got a high sensitivity, actually. Dr. Vaibhav, you may start.
Hello, am I audible?
Yes, Dr. Vaibhav.
Hello.
Yes, you're
Yes,
audible.
am I audible?
Yes.
Okay, good afternoon, everyone. I would like to take this opportunity to thank my HOD and unit chief for guiding me through this presentation. So we shall start with the presentation, the expanding head and the collapsing neurons.
Dr. Vaibhav, are you here?
Is my screen visible, ma'am?
Your slides are visible. Your voice is audible. You may start, doctor.
Okay. So, a case, 8-month-old male patient, second born to third-degree consanguineous parents, was brought to the pediatric OPD by his mother with global developmental delay. There's a history of loss of attend developmental milestones and a history of incessant crying with frequent hospitalization and seizures. Previous hospitalization. Child was apparently well till 6 months of age, after which child had multiple hospital admissions. First at 6 months of age for 5 days in view of seizures, which were 3 episodes characterized by toning posturing of all 4 limbs with upward deviation of eyes, each seizure lasting for less than a minute, followed by post-ictal drowsiness persisting for 2 hours.
Dr.
Child was
Vaibhav?
managed symptomatic.
Dr. Vaibhav,
Yes, ma'am.
can you do a slide share? Slideshow. Yeah, from the current slide. Yeah. Yes, you may proceed.
Yeah. So we start with previous hospitalization again. Child was apparently well till 6 months of age, after which child had multiple hospital admissions. First at 6 months of age for 5 days in view of seizures, which were 3 episodes, characterized by tonic posturing of all 4 limbs with upward deviation of eyes, each seizure lasting for less than a minute, followed by post-ictal drowsiness persisting for 2 hours. Child was managed symptomatically and was started on anti-epileptic medicines. After the illness, mother noticed he lost all his achieved milestones. Before this episode, he could hold his neck, which was achieved at 3 months of age, could roll over, which was achieved at 5 months of age, and had a bidextrous approach, which was achieved at 5 months of age, and had a social smile with recognition of parents, which was achieved at 2 and 3 months of age, respectively. Child was advised neurology opinion in view of regression of milestones, but there was a loss of follow-up. Second admission was at 7 months of age for 7 days in view of respiratory infection with seizure, for which child was managed with on HFNC and anti-epileptic medicines. Continue. ABG showed metabolic acidosis, which was high anion gap during the admission. Child was discharged with diagnosis of recurrent seizures and viral respiratory infection. Child and was advised to follow up after 1 month. Antenatal history, which was spontaneous conception, booked and immunized. Antenatal scans were normal, uneventful. Birth history, which was the term boy baby, LSCS, birth with birth weight of 2.5 kg, cried immediately after birth, NICU admission for 3 days in view of NNH for phototherapy. Developmental history, gross motor at the time of admission follow-up, Gross motor was no head control, fine motor no bidextrous grab, language milestones only baby was going, social and adaptive milestone recognizes mother. Overall DQ we found out global development delay with 34%. Family history, third degree consanguineous marriage, first child male alive and healthy, history of sudden infant death syndrome in one paternal sibling. Anthropometry, weight was 7 kg, which was falling under 0 to -2 standard deviation, length to 70 centimeter, +1 standard deviation to +2 standard deviation. Weight for length was -2 to -3 standard deviation. Head circumference was 48 centimeter, which lies under +2 standard deviation to +3 standard deviation. On examination, general exam, child was irritable, vitals, temperature normal, stable, pulse rate 132 per minute, respiratory rate 36 per minute, blood pressure was 94/62 millimeter of mercury, saturation was 98% on room air. On head-to-toe examination, it was observed that child had microcephaly and hypotonia in all 4 limbs. Systemic examination, cardiovascular S1, S2 heart, respiratory system, bilateral air entry present, work of breathing normal, her abdomen was soft, no organelle, bowels and head. On CNS examination, higher mental functions, child was irritable, modified Glasgow Coma scale for infants was 12/15, cranial nerve examination was normal. On motor examination, bulk was normal in all 4 limbs, tone was hypotonia in all 4 limbs, power was best observed, power was 3/5, reflex supervision normal, plantar reflex was extensor normal for age, and deep was brisk in both upper limb and lower limb. On sensory examination, child response to painful stimuli, cerebellum, no nystagmus, fundoscopy to no retinal hemorrhages was shown. On investigation, hemoglobin was found to be 8.3 gram per deciliter, total leukocyte was 11.8, platelet count 280,000, sodium 140, potassium 140, and bicarbonate, which was low, 12, and pH was 7.3, which showed high iron gap metabolic acidosis. ALT AST was mildly elevated. MRI was done, was performed on the day 2 of admission, which showed prominent CSF fluid spaces and Sylvian fissures, which showed battering appearance. Tandem mass spectrometry was revealed, which showed elevated levels of glutaric acid. Urine gas chromatography mass spectrometry (GCMS) showed elevated levels of 3-hydroxyglutaric acid, acetoacid, and glutaric acid with the presence of 3-hydroxyglutaric acid. GCMS is a confirmatory trace of glutaric acid type 1. Targeted gene sequencing was planned for the baby as a follow-up. Treatment, initially child was managed with supportive and symptomatic treatment with AED. Child was started on low protein diet, initially 4 days, rice kanji with added sugar to provide 120 kilocalories per kg per day. High doses of 200 mg per deciliter of riboflavin and L-carnitine 15 mg per kg thrice daily, orally gradually increased to 100 mg per kg per day, thrice daily were given. Parents were advised to report to the hospital for intercurrent infection. Differential diagnosis in this case was maple syrup urine disease, methylmalonic acidemia, propionic acidemia, lysine degradation disorder, and Canavan disease. In conclusion, this was a case of glutaric aciduria type 1 with timely diagnosis and treatment and appropriate dietary management. Individuals affected by glutaric aciduria can achieve significantly improved outcomes and quality of life. Early identification through newborn screening by dry blood spots significantly improves outcomes by enabling dietary restriction of lysine and tryptophan and carnitine supplementation to facilitate the excretion of toxic metabolites. Prenatal diagnosis can be done by amniocentesis at 16 to 18 weeks of gestation. These are the references. Thank you.
Thank you, Vaibhav, for presenting for such an excellent presentation of a very difficult case. Now, I request Dr. Shanti Ramesh, moderator, to say a few words.
Thank you, Vaibhav, for this nice presentation. And I would like to add that this disorder, glutaric acidemia type 1, is a very rare condition. It occurs 1 in 100,000 live births in worldwide. And India also, there are a lot of varying data from India. But again, it's a rare disease. That's what I want to say. And we should suspect this disorder. First of all, we have to suspect and make a diagnosis. Okay, for that, unlike other organic acidemias, they will present in the first 1 week of life or first, second week of life. But here, this glutaric acidemia, they present quite late. So this child, if you're seen, he was almost normal till 6 months of age, had perfect milestones, he was growing well, thriving well. It's only after 6 months of age, that's a typical age of presentation of this condition, that they will have recurrent infection-triggered encephalopathic crisis. And during this crisis, they have all the seizures as he has described. Then after that, they'll have neuroregression. So all the milestones which are gained, it all lost. So it's neuroregression after that, hypotonia, followed by dystonia because the basal ganglia is affected. So there are dystonia, movement disorders, and all that will happen. So with this kind of a presentation, and there's a progressive macrocephaly because all the toxins get accumulated in the brain. So there's a progressive macrocephaly. So if you have this kind of a presentation in later part of infancy with recurrent encephalopathic episodes, dystonia, macrocephaly, we always have to think of inborn errors of metabolism, particularly the glutaric aciduria type 1. And for this, it's easy nowadays. We can do this TMS, tandem mass spectrometry screening test, where at one shot we can have 40 the metabolic disorders being diagnosed at a cost of 5,000. And so this is a screening test, and from there we can work up to GA type 1. Okay, so it's very important to make a suspect and make a diagnosis. And making a diagnosis is got two implications. One, for the child itself, you have to put them on low glycine diet, as he said, and there are special formulations available in India itself nowadays. Then on rice kanji diet and all that, carnicine supplementation, all this can be done for the child so that they don't have recurrent episodes and further neurological worsening. And second most important is the prenatal diagnosis. Okay, so because this is autosomal recessive mode of inheritance, most of the IEMs are autosomal recessive, so they will have a 25% chance of recurrence. And this child also is the third degree consanguineous parents. So when they plan a next pregnancy, at 16 weeks, they can do an amniocentesis and go in for all the glutaric acid levels. And most important is look for the targeted gene. Everybody now presently, the first case and the second case is all about, okay, how they do a gene testing. So a targeted gene testing, looking for the glutaric acid, the GC DH gene, that's a pathogenic gene if you look for, and that's confirmatory. And if they can do it for the next pregnancy, then they can counsel. If it's affected child, of course, we will counsel them for termination because these children do not survive beyond infancy or the first 2 years of life. Okay, so there are two implications for making a diagnosis. And one more, I just want to add one more point about newborn screening. Okay, because routinely what we do is a short basic panel, about 5 to 7 disorders are being diagnosed. But when this is family history of a SIB death, like in this child, the father's, one of the sibling has died during early infancy. So unexplained SIB death or an unexplained developmental delay, that calls for an expanded newborn screening, wherein 40 disorders can be done with a diet blood spot at a cost of 5,000 rupees plus, so that you can pick up these disorders early and prevent them and prevent further neurological damage. Okay, so with these words, I'd like to stop here. Any questions or any comments? Welcome.
I would like to further add that any progressive dystonia in our child, look for organic acidemias, especially glutaric aciduria. And sometimes there is one tricky thing. There are two people who are called slow excretors and rapid excretors. In slow excretors, the glutaric acid levels of urine and blood may be normal. So you look for the glutarate carnitine levels may be high, and which may cause equal damage to the brain. And another thing about these children is they are liable to develop spontaneous subdural hematoma and easy bruising, including retinal hemorrhages. So this is mainly because of the accumulation of the toxic products, because they are unable to metabolize tryptophan and lysine, along with glutaric acid, can weaken the vessel wall and subject them to easy bursting of the vessels, leading to spontaneous subdural hematoma, easy skin bruises, and also retinal hemorrhages. Thank you. So I think this is the last case. Any more questions from the audience? Otherwise, we can end up the session. Thank you for giving me this opportunity.
Thank you, ma'am. Thank you so much for hosting the event successfully. And any questions? If not, we'll end up the meeting. Thank you so much for all other institute for giving us the cases, and we'll be meeting again with another set of cases in the next month. Thank you.
Thank you, all of you.